ARB, angiotensin receptor blockers. Okay, so the other class of drugs is calcium channel blocker. Okay, calcium channel blocker. Right now, you make your mind up that these drugs are also vasodilators, slightly different from angiotensin receptor and antagonists, ARBs and ACE inhibitors. And these are used again in hypertension, in angina pectoris, and in not commonly in congestive cardiac failure because of its some reasons. I'm going to discuss it in the go. And the next thing, I just want to remind you that these vasodilatory property of these drugs are solely responsible for decreasing the BP, okay, of a hypertensive patient. So these hypertensive patients, the main mechanism of action that we do with these kind of drugs are that they will vasodilate, which will venous preload, sorry, cardiac preload and afterload, okay. By dilating the veins, your preload is decreased, and by dilating the arteries, your afterload is decreased, so that your heart is able to pump more easily. Okay. So just before going to what are calcium channels and other things, I just want to go through this classification. Okay, so if you just mug up these names of these drugs, then we'll be talking about these drugs when I'm going to explain about mechanism of action and other things in this this chapter. Okay, the first thing you need to remember is though I have shown you three, you can see there are three. You can see there are three types: dihydropyridines, phenylalkylamines, which is verapamil, and diltiazem. Just remember these three subdivisions, okay, of calcium channel blockers. And what I wanted to tell you is you can draw a large big line over here. So here you can see dihydropyridines and non-dihydropyridines. The upper one is dihydropyridine, which includes nifedipine, amlodipine being far commonly used drugs. Okay, amlodipine is far commonly used drug. Where are the colors? So amlodipine is commonly used in hypertensive cases. Okay, and nimodipine is very short acting. Nifedipine is very fast acting. Okay, I'll talk about the differences between these drugs in a moment. And these two cumulatively will be known as non-dihydropyridines. Okay, verapamil and diltiazem. These are non-dihydropyridines, but they don't share some common structures or things. So they are different substances. Like verapamil is phenylalkylamine and diltiazem is benzodiazepine. So I will tell you right now that amlodipine or dihydropyridines are sometimes called dipins. Okay, so why dipins? You can see all the names, they got dipins as their suffixes. You can see dipin over here, dipin over here, and dipin over there. So commonly we call them as dipins or dihydropyridines. They are the synonyms. Okay, if somebody calls you dihydropyridines, don't forget this is dipins, and this is only one group: DSP, dihydropyridine, nifedipine, amlodipine, nimodipine, feldopine, and other dipins. Okay. And non-dihydropyridines, you can see there are no dipine suffixes as such. You can see verapamil and diltiazem, both of them, and there are not much drugs, only two drugs are there, so you can remember it quite easily. And these are called non-dihydropyridines. Okay. Dihydropyridines have no effect on heart, so I will be repeating this, don't worry about it. Dihydropyridines have no effect on heart, but non-dihydropyridines, they have some negative effect on heart. Okay, apart from their vasodilatory action, both of them will have vasodilatation. They are vasodilators, and the one at that this dihydropyridines, they have negative effect on heart. That means they will have contractility force will be decreased, heart rate will be decreased. But with dihydropyridine, they have no direct effect, but the effect on heart is there. I'll tell you what. The effect of heart will be opposite that of verapamil because of reflex tachycardia. You should be by now know in knowledge should be there what this reflex tachycardia is all about. I'm going to explain it briefly when the time comes. So just before going to all these drugs and mechanisms, pharmacokinetics and pharmacodynamics, you should understand how important it is calcium. Okay, calcium you can see is the fifth most abundant body constituent. You can see that after carbon, which is the most common thing that you have, and oxygen and hydrogen and nitrogen. These are the four most common elements that is we are made out of. Okay, and the fifth one is calcium. How important is that? You can see all this skeletal function is all the function of calcium. Okay, not only these bones act as the pillar of our body, but they are also used as depot of calcium in our body. Okay, and about 2% of our body weight, you can see these almost 2% of our body is calcium. 99% of this is in bones. Okay, this is the main storage site of bones. If the calcium levels go down, then the bone density goes down because the blood levels of calcium will start pulling calcium. Blood will start pulling calcium from the storage site, that is bones. And if it is loss of bone, calcium comes out of the bones, then the bones become more fragile and prone to fractures. Okay, and 1% of plasma and all tissue and cells is calcium. And calcium is function of calcium is unlimited, that we cannot discuss in only one class. But I'm trying to give you some examples, some things where you can see what are the physiological roles of calcium. First thing is it controls excitability of nerves and muscle cells and regulates permeability of cell membranes. That means nerves and muscles, they are not going to work as they are intended if there is no calcium. That means you are not able to pick anything. I cannot move because muscles need calcium to move. Not only calcium, there are other factors apart from calcium, but without calcium, no force is going to happen. So you are not going to exert any force over there. And not only with muscles, you are not going to transport these electrolytes and other neurological signals in the nerves because of calcium is not exciting the cells, because responsible for not only contraction but also for release of acetylcholine and other neurotransmitters. Okay, not only acetylcholine, noradrenaline, adrenaline, everything, dopamine, whichever is stored in a sac or a cavity inside the cytoplasm, all of need calcium to get released. Okay, not only that, you need calcium to get released, your sweat glands and other things, you need calcium all over the place. Okay, and even for contraction of muscles, contraction of smooth muscles in your intestine, for peristaltic movement, contraction of your blood vessels, okay, for regulating your BP, all the things are needed. Calcium is needed for everything. Okay, intracellular messenger, the next important thing. Okay, so once the receptor like adrenaline is excited, they have without hormones, sorry, without calciums, intracellular calciums inside the cell, those excitations also not mean anything. Okay, so hormones, corticoids, drugs, anything that you give to a patient without calcium as an internal messenger, second messenger. Calcium is also a second messenger. Okay, like in the receptors I talked about IP3 DSG system and other systems which propagates information from the receptor to the rest of the cell, and which executes the purpose of this drug or the hormone or anything that excited the receptor. Okay, so without this, the receptor excitation fixed, some of the receptors will not work. Okay, impulse generation in the heart, very important. Okay, so this is basically, if this function is used for cardiac arrhythmias, guys. Okay, so to impulse generation in the heart, that is sinoatrial node, SA node is not going to produce any impulse in the to initiate heartbeat without calcium. That means calcium is necessary for your heart beating, so it is very essential for your life as well. Okay, so automaticity, and not only that, the propagation of all these neuronal signals towards your heart muscles is also blocked. That means AV conduction is also blocked, and conduction in the Purkinje fiber is also blocked because of calcium. Without calcium, this is not possible. Okay, and not the last one. Okay, the major ones I discussed last but not the least, but the not the last one. There are many other functions for this calcium, but one of them is coagulation of blood. Okay, so there are so many clotting factors, other factors in blood which help the blood to coagulate, and not only coagulate, to remain fluid inside the body, and when it's exposed outside, it needs to get clotted. Okay, that thing is highly responsible, highly dependent on this calcium. Okay, not only calcium, there are other factors you learn in hematopoietic system, but calcium there is very essential constituent of all these functions. Okay, so physiological functions, I briefed it in a very precise manner. I hope you will go through other sources in library and other in the internet and other internet sources where you can find more functions of calcium. So what are these blockers? Blockers, the mechanism of action is very simple. Okay, so only thing it does is it will block calcium channels. Okay, there are calcium entry blockers. That means this channel will be blocked by how the calcium will not enter the cell. So that is all the mechanism of action. But while you are explaining the mechanism of calcium channel blockers, it's better that you explain how calcium works. Okay, how calcium contracts and releases this dilates or relaxes the muscle in the cell in our body. So that thing should be explained. I'm going to try to explain that in a moment. But the mechanism here precisely is that it just blocks the calcium channel. Okay, and I'm going to discuss how many different types of calcium channels are there. So they are used in hypertension, angina pectoris, and arrhythmias. Okay, we are going to discuss about that. So, how many types of calcium channels are there? Calcium channels you can see are basically of three types. There are more. Okay, not only three. There are more calcium channels. There is a stretch sensitive calcium channel, which are considered to be leak channel as well sometimes. But I'm going to tell you briefly about it. So the most important one here is voltage gated calcium channel. What do you mean by that? That means that the potential difference in the membrane, cellular membrane, will initiate the opening of this channel. Okay, so that the calcium can get in. So what I mean about this is when the cell is hyperpolarized being the potential difference in the membrane going highly negative. Okay, minus 40 millivolt or less. In that case, the cell is known to be hyperpolarized, and in that moment, the calcium channel opens. Okay, at that moment. So that is one function. That is one function of this voltage gated channel. That means it only opens where there is hyperpolarization. Okay, the difference between inward and outward membrane of the cell membrane is that much, minus negative 40 millivolt. The next one is receptor operated channel. That means there will be a receptor like adrenaline, noradrenaline receptor, which are basically sequentially will activate this calcium channel so that calcium can get in. Okay, so and this will force this calcium channel to open even the cell if the cell is non hyperpolarized. Even it is in depolarized cells, The difference, potential difference between cell membrane inside and outside is very less. It might be 0 or -10 or sometimes even positive. In those cases also, when this voltage gated sensitive channel voltage gated channels will never open, this can open. Why is it needed? It is needed when you need to open without this maintaining these charges. Okay, that when the receptor opens, then it will force the channel to open. The third one is leak channel, which has no function. Function is there, sorry, no trigger for opening. Okay, no voltage sensitive. It's not voltage sensitive. It is not a receptor. It's always open, and most probably it's unidirectional. Okay, from outside to inside. Only calcium it will leak the channel in, leak the calcium inside when anytime. Okay, but getting out is very difficult. It needs some ATPs to take them out. But leak channel are the channels which are small ones, and very slowly they will let calcium inside. But it doesn't depend on anything. Okay, and one of the leak channels is now considered to be stretch sensitive channels. What do you mean by that? Is when the muscle is stretched. When you stretch the muscle, then and stretch to the full extent, then your body will think that, oh, now the power of this muscle is not sufficient, so I need to bring more channels, more calcium in to improve the power of this muscle. So for that, there is a sensor of stretch. When the muscle is overstretched, then these leak channels might again open. Okay, so those type of separate type of stretch dependent channels are also included in leak channel, where nowadays it's now being differentiated in most of the books. Even in KD Tripathi, you can see the mention of that thing. Okay, there is a small letter writing in KD Tripathi in calcium channel blocker chapter. You can go through that. Okay. So why and though I explained you these types of channels, but the calcium channels are only working on voltage gated channels. Okay, voltage gated channel, because we are not exciting the receptor, so that the receptor gated channel is not utilized. And even leak channels are independent of anything, so we cannot do anything for that. Only thing we can manipulate here is voltage gated channels. And how there are, and nowadays voltage gated channels drugs has been proliferated, and these are dihydropyridines. Okay, non-dihydropyridines, which was verapamil, basically was the first calcium channel blocker to be get discovered, but nowadays dihydropyridines has taken over. Okay, so there are three types of voltage gated channels. Okay, L type, that is long lasting current. This is the target of our chapter, this chapter, calcium channel blockers. We target this L type. Okay, T type, we use it but not for hypertension. N type, we use it but not for hypertension. Okay, so L type. So now we narrow it down, and most of the calcium channel blockers are blocking L of this channel. Am I there, guys? Am I speaking to myself?
So we are listening.
Okay.
Yes, sir.
I need to confirm in between. I need to confirm in between. Sometimes I get lost. The current, electricity gets lost. The connection gets lost, and then I speak to myself without the connectivity. So to make sure, I sometimes ask you. Okay, guys. So cardiac muscle, in endocrine cells, present in smooth muscles, cardiac muscle, endocrine cells, neurotransmitters release, everything is L type. Okay, so L type is long type. Why do you call long type? If you compare it to this T type, this will remain open for a longer period of time, which we can use it as our drugs effect. Okay, but T type is very transient, very less. It will make it open for a short period of time, and especially these T type of channels are present in brain. Okay, synovial node. So why it is T type in synovial node? You know that your heart beats more than 50 times, 80 to 100, 120 times a minute. So every time SA node needs to generate a new impulse, the effect of this calcium needs to peak and then go down and then again it peak 60 or more times in a minute. So it needs to get very fast. Okay, it's to very fast. So this thing is used for this pacemaker and fast things. Okay. And N type is neuronal one, okay, neuronal ones, which is responsible for neurotransmitter release in the synaptic cleft, acetylcholine, noradrenaline, bradykinin, other this side of neurotransmitter release is responsible for N type. And for cardiovascular system, and especially in this class, we're going to talk most of the things about L type blockers. Okay. So the mechanism of action is this one. So I just mentioned everything in this slide. Calcium channel blockers block influx of calcium inside the cells. I have been reminding about you this since the beginning of the class. Block L-type voltage sensitive calcium channels only. So I just told you about this just a moment ago. We don't talk about T-type and N-type, but only L-type. Okay. Voltage sensitive channels. Influx is necessary for contraction of smooth muscles and cardiac muscles. So why I'm emphasizing this smooth and cardiac muscle, we'll come to know that this is smooth muscle is responsible for vasodilatory action and cardiac muscle is responsible for cardiac action. And I just want to repeat it once more that dihydropyridines will have no effect on cardiac muscles. That means if you are talking about verapamil and diltiazem, which are non-dihydropyridines, it's about cardiac muscle. It will act in the cardiac muscle negatively. I'm going to talk about that. But this dihydropyridines will only act in smooth muscles. So again, I jump back to the classification, and I showed you this. I showed you this in the previous slide that dihydropyridines, nifedipine, amlodipine, nimodipine, felodipines are called dihydropyridines, and there are all dipines. Okay, dipines, and phenylalkabine and diltiazem. These are non-dihydropyridines. One thing I have to add in this slide is that this nifedipine is more like a lipophilic. Okay. So dihydropyridines are lipid soluble drugs. Dihydropyridines, nifedipine, amlodipine. That is why nimodipine is used for CNS things. I'm going to talk about nimodipine. Please remember, this is shortest acting. Okay. And useful for subarachnoid hemorrhages. It comes in MCQs. Nimodipine is very essential for subarachnoid hemorrhages. I'm going to talk about that in a moment. And it's very short acting. And these are easily penetrated into the CNS and from the GI tract because these are lipid soluble drugs. But verapamil and diltiazem, these are water soluble drugs available for IV use as well. But these dihydropyridines are basically oral drugs, and phenylalkylamine and benzodiazepine, verapamil and diltiazem are available for IV use as well. Okay. So the pharmacokinetics is of calcium channel blocker, you can see, is they are orally active, high fast effect is there, high plasma protein binding, okay, and extensive metabolism to all the units, all the members of this drug. Okay, so what does this mean? The clinical significance will be high fast effect. That means the bioavailability is not very high. Okay, so it will be destructed. It will go to extensive metabolism. That is why the bioavailability is low. We need to take high doses to achieve a certain effect, a certain level in the blood. High plasma protein binding is there, so it will work for a longer period of time because it will go from the blood circulating in the blood in active form to an inactive form, which is bound to the proteins in the blood. And but what will happen to those? What is the fate of those drugs that is bound to the protein? It will get released when the free drug is finished. They are used up or they are excreted and they will get released into the circulating blood. So as an active form. So these bound drugs are not active. That means the drug effect will go on for a longer period of time. Okay. And I just mentioned in the previous that verapamil and diltiazem are only used IV, not only IV but IV also. But others depends are only used orally. To show the mechanism of action, I just tried to explain you before this slide. The only mechanism of action is that you can block this calcium channel. Okay, calcium channel blocker. So this is calcium channel, and our drug is blocking this. This is the only mechanism that you need to understand. But to understand deeply and then to be able to explain in your examination or to the external or to your interviewer that you need to understand how calcium works. Okay, so this is very common in most of the classes. I have explained this several times in ANS as well, that calcium, when it is opened, it will get inside from this calcium channel. L-type voltage gated calcium channel. Okay, guys, L-type voltage gated calcium channel. When this potential difference is less than minus 40 millivolt, then this calcium enters. So this calcium itself can bind to calmodulin, okay, or plus it can initiate the triggering. This is a trigger calcium, the sarcoplasmic reticulum, which is full of calcium. Okay, so this voltage gated channel allows this calcium to come in, which in sequence subsequently will excite the sarcoplasmic reticulum, is known as trigger calcium molecule element. That this one will release even more calcium down to this pathway. Okay, so again this will combine with calmodulin, and this calcium calmodulin complex is the one that is responsible for exciting the change of myosin light kinase MLCK to MLCK, tropomyosin, and then this light chain will as actin and myosin interference, which will, this is a separate thing that you can learn in biochemistry and microbiology, physiology, how muscle get contracted. Okay, by changing this form from actin myosin system. Okay, so that thing is initiated and maintained and maintained by calcium. Okay, without calcium you can see nothing happens, so only relaxation will be there, the contraction will not be there without calcium. Okay, this is the basic mechanism of action of calcium. And just for your reminder, the mechanism of drugs is just blocking the receptor, nothing else, just preventing calcium to get inside the cells. So pharmacological effects, you can see that I have been highlighting these two things. Okay, cardiac and smooth muscles. Cardiac and smooth muscles effect are the main mechanism of action that we require for treatment of these diseases that I'm going to talk about. So dihydropyridines are basically in smooth muscles. So the main role here is vasodilatation. Dihydropyridines will provide vasodilatation, but verapamil is preferentially affect the heart. So heart, it has that the vasodilatory action like dihydropyridines, but it has some action on the heart, and the heart is, it has action like negative chronotropic action. So what do you mean by that? Negative chronotropic, negative dromotropic, negative inotropic. So I just told you that for propagation of impulses throughout this heart neurons, Purkinje fibers and other pathways, you need calcium. Without calcium, this is going to slow down. So the nerve conductivity is slowing down. Even SA node is without calcium, it will start producing impulses quite infrequently, slowly. So heart rate will go down, negative chromotropic effect. The conduction velocity will go down, negative dromotropic effect. And without calcium, the force of contraction is going to go down, negative inotropic effect. Okay, so the overall function of the heart is going to reduce. Do you remember any drug that did the same from ANS? Anybody can answer the similar actions on the heart? you learned in ANS? Which drug? Nobody? Don't you remember beta blocker, guys?
We remember, sir.
Oh, why didn't you tell me before then? So beta blocker, you can remember, you remember I taught you that class is that it has negative inotropic effect, negative dromotropic effect, and negative chromotropic effect. Okay, inotropic contractility force, dromotropic the velocity of conduction, and chronotropic is the initiation of the heartbeat. Okay, so that thing is very similar. This verapamil is very similar to beta blocker only in the heart. Okay, not anywhere else. I'm not going to talk about that verapamil is very similar to beta blocker in the heart. And diltiazem is more like mediatory, okay, in between dihydropyridines and verapamil. Okay, still it's called non-dihydropyridines, but verapamil, and remember, verapamil was the first drug to get discovered. Dihydropyridines came later on. So verapamil was the first one, and when it was discovered, I think it was in 1940s, I think. At that time, it was not known how this verapamil worked. Okay, and it was later on, I don't remember the scientist who discovered the function, but it is very similar to Frankenstein. Frankenstein was the, if you remember, there is a story in English literature that lightning caused one maniac doctor. He used lightning current to revive a corpse, dead body. Okay, Dr. Frankenstein, I think. So the name is very similar to Frankenstein, I think. This verapamil who discovered the mechanism of action of verapamil. I think is from Germany. I don't know. I'm not very sure about it. You go through that, but the main point here is verapamil was the first one to get discovered, and verapamil, because of verapamil, calcium channel blockers were discovered. After getting itself discovered, it was found out that this verapamil was blocking this calcium, and later on we found other drugs like very importantly dihydropyridines, which work very similar to verapamil, and nowadays these drugs are more commonly used. Nifedipines are more commonly used. So pharmacological effects, I'm going to talk about again two things. Okay. So I have explained you just for your note and to remind you very clearly so that you never ever forget is smooth muscles. One is relaxed arterioles more than veins. So relaxation. Okay. So because of this, there is all the functions that we want from this dihydropyridines. Okay. DSP are the most prominent action on smooth muscles and least by verapamil. So this smooth muscle action, verapamil also has some action, but it is far less than what dihydropyridines can offer you. Okay, nifedipine and basically amlodipine. But not only for relaxation of arterioles and veins, but also other smooth muscles like bronchial smooth muscles, biliary smooth muscles, intestinal smooth muscles, uterine smooth muscles. So this will either generate some some usefulness for this drug or generate some adverse effect. For example, bronchial asthma patients is very good. So it can dilate the bronchus. So in bronchial asthma COPD patient, this might be good. In biliary patients like with cholecystitis, cholecystolithiasis, that means the inflammation of the gallbladder or inflammation of there is a presence of some stone or some structures or foreign bodies in the biliary tract, and even without anything, there is just a contraction of biliary vessels in those moments, and it will create severe pain. Okay, so colicky pain. In those cases, this can effectively dilate all those things. Okay, and ease your pain. Intestinal, that means this will give you adverse effect, guys. Intestinal relaxation will lead to constipation. Okay, because there is be no adequate peristaltic movement, it will lead to constipation. Okay, so calcium channel blockers, one of the adverse effects will be constipation. How easy is that? Very easy. And uterine again, it relaxes the uterine muscles. So if you give it to a pregnant woman, then there is a threat of getting aborted. Okay, so it has some use. If somebody has premature labor pain where the baby is not yet matured, but the woman is feeling pain, labor pain, then you can premature pain, you can block that by this drug. Okay, and smooth muscles, obviously it can dilate all the smooth muscles, like not only in bronchial and intestinal smooth muscles, but the other ones as well. So DSPs are most prominent action in smooth muscles. So DSPs, remember, dihydropyridines, nifedipine, amlodipine, and other dipines. Okay, has the more prominent action, smooth muscle one. But the other one is the second one is heart. Okay, impulse generation is SA node, AV node, conduction is reduced or blocked. Negative chronotropic and dromotropic. Reduced cardiac contractility. I just explained you that the force of contraction is also reduced because of low concentration of calcium inside the cardiomyocytes, and it will give you negative inotropic effect. So negative inotropic effect will be produced with these drugs. You know that. And then the most important thing coming is verapamil. Sorry, verapamil is the one, and diltiazem is the second one. But DSPs, dipins, and other dipins have no action. Alright, guys, just don't forget about this no action. No direct action, but they have some effect in the heart. That will be tachycardia. So there is a difference. Okay, guys. Verapamil will produce bradycardia, but nifedipine and other dipins will produce tachycardia. That is the opposite. But I'm still telling you that this tachycardia is action. Directly, it doesn't do anything to the heart, but what it does is it will reduce the overall peripheral resistance of your blood vessels, so that the BP goes down. As soon as our physiology detects that BP going down, it tries to compensate to increase that BP. It thinks, why is this going down? I'm not doing anything. My physiology, my brain, my body is not doing anything, but the BP is going down. It doesn't realize that we have taken drugs. So it tries to put it up back to the normal as is its physiological. For a hypertensive patient, his physiological blood pressure is high, isn't it? So we want to drop it down. When we use this calcium channel blockers, nifedipine, to make it down, our body will oppose that. Okay, so for that, what it tries to do is it will increase the heart rate and contractility force of the heart. So it will cause tachycardia. Since it has no directly blocking that action, it doesn't block that action, this nifedipine and dihydropyridines, it will show some tachycardia. So reflex tachycardia will be there. But with verapamil, am I online?
Yes, sir.
Yes, sir.
There
Yes,
was
sir.
power loss, so I thought I've gone down. So I was talking about this verapamil, and now verapamil is able to block that tachycardia, isn't it? So that physiological tachycardia, verapamil is effectively blocking that thing. If it blocks that thing, then there is no defect tachycardia with this verapamil. So this thing is very, very important for the use in angina pectoris. Okay, angina pectoris is the ischemic heart disease. Angina pectoris is a type of ischemic heart disease. Ischemic heart disease by itself, your name suggests that there is ischemia. What is ischemia? The blood is not adequately supplied to the heart. Okay, so for that, if the blood is not supplied to the heart and heart is beating faster, then the demand of heart for blood is high, but blood is not being supplied. There is a deficiency of demand to ache, pain, and show symptoms. That is what angina pectoris and MI is all about. So for this, sometimes these nifedipines might be contraindicated, might worsen because it will increase the heart rate. But verapamil will be more preferential or for the use for angina pectoris. Okay. So two things. Just don't forget these two. One, smooth muscle, and the heart muscle action of this heart of this thing. Okay, drugs. Sorry. So going individual to the drugs, verapamil. Okay, the first one we are going to discuss, but the not most, by far not the most commonly used. Okay, but this is the first one to get discovered. So I'm talking about this for the in the beginning. Dilates arteries directly. Okay, so it has some It is a calcium channel blocker. So by the mechanism I just explained before these slides, it will direct the arteries, obviously because it's a calcium channel blocker. But the most important, other important mechanism of action additional is that it will block the action alpha also. Alpha receptor blocking action is there, though milder. So what will be the net effect? Alpha blocking. Again, if you block alpha receptor, vasodilatation will be occurring there, isn't it? Alpha receptor always vasoconstricts, if you remember ANS, isn't it? In the blood vessels. So alpha 1 receptor, because of blocking that action, blocking that alpha receptor, again there will be more vasodilatation. So basically the effect is it. And the adverse effect is nausea, constipation. Why constipation? Because of blockade of peristaltic movement in the intestine, and bradycardia. Why? Because of direct effect in the heart. Okay. It has blocking the calcium channels in the SA node and AV conductivity. So others, flossing, headache because of dilation of the venous sinus in the heart, ankle edema. Again, vasodilatation causes accumulation of fluid in the interstitial tissues, not only in the ankle, all lower limb. There is a very distinct adverse effect all these calcium channel blockers, but it is more with non-dihydropyridine. Sorry, it will more with nifedipine and amlodipine. Amlodipine as the least, but nifedipine and nimodipine, they cause more like ankle edema, but verapamil has slightly lower incidences than if you compare it to nifedipine. Cardiac arrest may occur when given IV or given with sick sinus. So when you are giving verapamil IV, you should be optimally careful about it. Okay. Why? Because it can block all the impulses of SA node, and then not only that, it can block all the movement of the heart and it can freeze. So that is cardiac arrest. So you should be very, very careful when you are giving, especially if you are giving IV. And on top of that, if the person is already having sick sinus, this means the sinus node is sick by some reason. It is sick and it is already producing less number of beats. In that case, again, you should avoid using verapamil at all. Okay. So interaction, you should never ever give it with beta blocker. I just mentioned this in the previous slides that the action is very, very similar. So it will potentiate each other. So there will be the adverse effect. It's very dangerous. Again, you can get sick sinus. You can get blocks, heart blocks. Okay, and sometimes it might get decompensated, and the patient may even die. Again, there is a new drug, digoxin. We'll be talking about in the coming classes in cardiac failure. Digoxin is a positive inotropic drug that will increase the force of contractility of the heart. So it can increase the toxicity, and digoxin is very highly toxic drug. Okay, guys. So because of this action with excretion, interference with excretion of digoxin, verapamil and digoxin will compete each other for excretion from kidneys. Okay, for that it will decrease the excretion of digoxin, and since digoxin is very toxic drug, slightly change in the blood of digoxin level will increase the toxicity of digoxin manifold. I will talk about digoxin when I talk about calcium channel blockers, congestive failure in the coming class. But you need to understand right now that this toxicity of digoxin, which is already a toxic drug, verapamil can increase that. So you should avoid using them together. Diltiazem, if you know verapamil, guys, diltiazem is very, very similar. Clinical dose produce consistent fall in BP with little or no change in heart rate. So like verapamil, it has changed the heart rate significantly. Diltiazem somewhere in the middle. Okay, just I told you that. Adverse effects very similar to that of verapamil. I'm not going to discuss it in detail. And interaction again the same with verapamil. I'm not going to talk about that in detail in this slide as well. So if you talk about nifedipine, which is the dihydropyridine now, is short acting, rapidly dilates the arteries. Okay, and it is very short acting and rapidly acting. Within minutes it will start acting. So why it is, and it has prominent tachycardia. Okay, prominent reflex tachycardia. The most tachycardic drug of all dihydropyridines is nifedipine. That is why it will increase the cardiac output. So we should not use this nifedipine for in cases with ischemic heart disease. Okay, mild natriuretic action. This means it will release some of the salt from this body, and has no direct effect in heart. So the takeaway message from this slide will be it is very short acting. Because of that, we can use this as emergency reducing the blood vessels, blood pressure in emergent condition, in emergent hypertension. But for long sustained prophylactic or what you call is maintenance dose for hypertensive patients, we don't use nifedipine. Okay, we use only in emergency conditions, and other uses of nifedipine is now declining. So right. And you know that this is this dihydropyridine, so it has no effect on the heart. Okay, you know about dihydropyridine not having effect on the heart. Adverse effect, palpitation. Why this palpitation is there? It is because of the reflex tachycardia. Flushing. Why it is there? Because of dilation of blood vessels in your face and your neck area, blushing area. Okay. Ankle edema, one of the prominent problem created by this nifedipine. Hypotension, obviously, it is treating hypertension. If it is overdose, then hypotension, headache because of lowering BP and accumulating the blood in the head. Drowsiness and nausea minimized by low starting dose. So frequent dosing or SR formulation, slow release formulation. Okay. So the thing here is you need to give this drug slowly because it is acting very fast and it is acting for a short period of time, which is not very convenient for us to use it in regular basis. And since the peristaltic movement of the urinary tract is also disturbed in persons who are suffering from prostate hypertrophy or other difficulty in voiding urine, you should avoid this drug because it will hamper those patients. Again, it can hamper the diabetes control as well. Okay. One of the thing will be, it will be hampering the release and production of insulin. So by far, amlodipine is the most commonly used drug. So it is slow acting. So palpitation, flossing, headaches are very less. It's there. But if you compare it with nifedipine, amlodipine is by far the commonest drug. Okay. Why? Because of all this effect that it is not very fast acting. It is longer acting than nifedipine, and it is reduced. The palpitation is quite low. Flossing is quite low. Headaches are not very common. So this is used. And again, higher oral bioavailability is there, and it can distribute in any part of your body because it is lipid soluble. It can even enter your brain, but lesser than nimodipine. I'm going to talk about that. Long THAP provides a smooth BP than nifedipine. That means amlodipine can be prescribed once a day dose. Okay, that will be very convenient for patients that is suffering, who are suffering from hypertension. This amlodipine. Okay. And S amlodipine is the isomer of amlodipine. Okay, levo isomer, or I don't know which one is this, but this is an isomer of amlodipine, which is in many trials, many clinical trials, they are considered to have lesser ankle edema. Okay, guys. So ankle edema is very swelling of your feet is very common adverse effect of amlodipine and all these dihydropyridines you will encounter in your life. So you need to understand and remember this ankle edema thing. Nimodipine is the shortest acting, so it penetrates the BBB very easily. Okay, that is why it is used in subarachnoid hemorrhages. Okay, guys, I have written this there. Yeah, subarachnoid hemorrhage. What is this in the subarachnoid space? Blood leaks out. So to maintain the leakage of the blood, immediately when there is hemorrhage, the first thing our body physiologically does is to contract the blood vessels around it, so that the blood vessels, the bleeding occurs in minimum. Okay, so this adverse effect, if it is in brain, if it is in blood vessels or is in hand and feet, no problem. Sometimes, not sometimes, occasionally, all the time, this helps. Blood vessels will contract, the bleeding will go down. But if it is in brain, then if blood vessels will contract, then there is a high risk of getting ischemia after that. Okay, to prevent secondary ischemia because of cerebral vasospasm following subarachnoid hemorrhage, we always use nimodipine in subarachnoid hemorrhage. This is the emergency drug for that. Okay, as soon as the patient comes to your emergency department, if you are working in the emergency, and if you find a person who, and you have done a CT scan and you have confirmed the diagnosis of subarachnoid hemorrhage. In other types of hemorrhage, it might worsen the cases because it will dilate the blood vessels, isn't it? But in subarachnoid hemorrhage, when there is constriction of blood vessels physiologically, there you can prevent neurological deficits. You can prevent ischemia in other parts of the brain, so that your neurological deficit, paralysis will be minimum. Side effect again with the same: headache, fasting, dizziness, palpitation, and nausea. Okay. So you have this chart, guys, in KD Tripathi as well, comparing nifedipine, beratapamil, and diltiazem. Nifedipine being dihydropyridine, okay, and these are non-dihydropyridine. Okay, dihydropyridine, you can see heart rate, though indirectly it will increase, but with verapamil and diltiazem, verapamil will either increase or not, but diltiazem will always have a negative effect, decrease. AV conduction, nifedipine has no effect on AV conduction, but verapamil will highly depress the AV conduction, negative dromotropic. Contractility of the heart is increased by nifedipine, but with verapamil is decreased. Okay, and cardiac output is increased because it has reflex tachycardia. Because of reflex tachycardia, cardiac output will increase, but with verapamil, because it will depress, it has negative dromotropic effect, it will decrease. Okay, and vascular smooth muscle relaxation, that is, this one is used for hypertension. Okay, guys, this is the sole for hypertension. You can see nifedipine is by far 3 pluses. Vascular smooth muscle relaxation 3 pluses for nifedipine, 2 pluses for verapamil, and diltiazem 1 plus. Okay, the least effective of all these drugs in hypertension is diltiazem. Okay, so this, if you understand this chart, you can understand all the effects of differences of these 3 drugs, dihydropyridines and non-dihydropyridines basically. Uses, first one is hypertension. Again, it is how the mechanism of action. Because of blocking the calcium channel, it will relax the smooth muscle of the blood vessels, which will dilate the blood vessels. By in turn, it will decrease cardiac output. Preload and afterload of the heart. Okay. Cardiac arrhythmias, basically used is the cardiac selective drugs like verapamil and diltiazem, used in PSVTs, paroxysmal supraventricular tachycardia. All of paroxysmal is all of a sudden starting all of a sudden. Supraventricular is from in the auricles, tachycardia, or your auricles are now beating very fast. Okay, atriums. So this is very dangerous, considering that this might go down to ventricular tachycardia, not supraventricular but ventricular, VT. If it goes to VT, then the patient will die. Patient high risk of losing the patient. Angina pectoris, especially variant angina. We'll be talking about what is this. I'm not going to use variant angina right now, but calcium channel blocker might be contraindicated in other type of anginas, but it is very useful in variant angina, and I'm going to talk about variant angina when I talk about ischemic heart disease. Short-acting DPS should be avoided. Short-acting meaning nifedipine. Okay, nifedipine should never be used. Hypertrophic cardiomyopathy. So because verapamil will slow down the heart rate and slow down the force of contraction, it will reduce the enlargement of the heart. Okay, in case of hypertension and other diseases, it will reduce the hypertrophy of the heart. In premature level, I just told you about this. If the female is prematurely feeling labor pain, then you can use nifedipine to block this premature tocolytics. Okay, premature labor will be blocked. Verapamil can be used in migraine. Again, verapamil will dilate the blood vessels in the brain. So verapamil is used for migraine as well. And in case of nocturnal leg cramps, okay, muscular cramp, if you have experiences quite painful condition, there also blood vessels dilatory action will help in this situation. And last but not the least is Reynolds episodes. Now that is contraction of blood vessels in the tip of your fingers and other things, especially in cold. Okay, you have seen so many people feeling getting their hands blue in the cold, and their numbness and tingling and sensation and sometimes swelling because of ischemia in the tips. So that is a renal disease, renal phenomena, and that can be avoided by using calcium channel blocker by dilating the blood vessels in the fingers tips. And this is dietropyridine is quite useful with this. So last but not the least, guys, read this slide. I have gathered some information from this from books. Okay, so some epidemiological studies reported an increased risk of myocardial infarction or mortality in patients receiving short-acting nifedipine for hypertension. Okay, so because of this, now nifedipine is not used for used with hypertension patients. Okay, it is therefore recommended that short-acting dihydropyridine is not used for hypertension. Nifedipine. I'm talking about nifedipine here. Okay, sustained release calcium channel blockers or calcium blockers with long half-life like amlodipine can be used. Provide smoother blood pressure control and appropriate for treatment for chronic hypertension. So nifedipine we don't use for chronic hypertension, only for releasing quickly releasing pressure in emergent hypertension conditions. Oral short-acting nifedipine can be used in emergency management of severe hypertension. So I was talking about this only. Okay, preferred in elderly because calcium channel blockers prevent stroke. Okay, in elderlies, we don't use verapamil. We use verapamil and nifedipine equally for older patients. Instead of using other drugs, we use calcium channel blocker. Okay, I think this much is for today. Time is already up. If you have any questions, you can go ahead and ask. Any questions? No? If no questions, then you are free to leave. Thank you very much for listening. Did you understand at least, guys? Answer me if you understood or not. Yes, no question. Am I online?
Yes, sir.
Yes, sir.
Yes,
That
sir.
is the only question I'm going to get answer to. Eh? Am I online? Yes, sir. Other than that, no questions will be answered. Okay, no problem. I hope you understood. And this much for today. You are free to go. Bye bye.